Perfect. And everyone can hear me. I think everyone's in the room. Perfect. All right. So let's get through these. And great. So I think we have about 12 questions. What did people answer for question 1? Feel free to speak up. And I should introduce myself first. Sorry, I'm Luis Tulloch. I'm one of the infectious disease doctors over at the Seattle VA. I'm the lead for stewardship. So great. So with that, oh, great. We have a poll. Fantastic. So what did people pick? A bone biopsy and culture. Fantastic. All right. That is correct. So the key point here is that if you have a patient with osteomyelitis that is stable without any local signs of infection, you can wait before you give antibiotics and get as much diagnostic certainty and cultures before you start antibiotic therapy. So a little bit more in depth of an explanation here. And, essentially when I think, when I have a patient with a diabetic foot ulcer, I try to follow this checklist in my head. The things I'll talk about mainly are identifying osteo, obtaining cultures, and what empiric antibiotics to choose. The tests that you're going to be relying more in terms of clues to identifying osteo are your probe to bone, your ESR, and your X-ray, and your MRI if you have a question after those. Usually, a lot of those initial tests are done in the emergency department, and depending on your pretest probability of osteomyelitis, you can get a diagnosis pretty quickly. But again, like I said, if there's any question, an MRI will be highly sensitive and specific for osteomyelitis. This is just a reminder that even MRIs are non-specific, so you kind of have to have a good eye to identify things that in the differential, like reactive edema or Charcot arthropathy. And the point of cultures for diabetic foot ulcers and osteo, at least the main point is to identify the organism and target your antibiotics. And the question always comes up if we can do superficial cultures versus deep cultures. And there's a lot of retrospective studies on it, but the bottom line from all of them is that there is poor concordance between a superficial swab and a deep culture. So we prefer deep cultures. There may be some concordance with more severe ulcers, more deep ulcers, or if there's pus and Staph aureus. In terms of what empiric treatment to choose once you have a bone biopsy or a deep culture, a lot of data here that you guys can review afterwards. But essentially, the organisms to target are Staph aureus, strep, a little bit of Enterobacteriaceae, and for more severe infections or infections with gangrene or ischemia, anaerobes. And I have kind of a summary slide stating that, essentially. All right, and then I'll skip the last few parts just so we can get through more questions. Do you guys have any questions about that first question? Okay, and feel free to interrupt me. If there's too many slides, say, hey, dude, there's too many slides, stop it. So don't worry about that. All right, question 2. What did you guys answer for question 2? Is a patient with severe C. diff?
E is not on this poll option.
Uh-oh.
We chose E.
You chose E. Ooh, okay. Oral vancomycin and intravenous metronidazole. Some folks picked D. And some folks picked C, oral metronidazole. All right, so we have a interesting spread here. Great. Oh, someone put in an E in
Sorry.
there. Okay,
Just
that's
a
fine.
bit.
All right, let's see that. Yeah, yeah. All right, we'll try the poll again. All right, D and E. All right, oral Vanco and metronidazole IV. Fantastic. All right. So the answer was the oral vancomycin by itself. And I think the STEM described a patient with an initial episode of severe but not fulminant C. diff infection. And that, I think, was the difference between D and E. And for this question, this table is going to be very helpful to review before your MKSAP. It's essentially the two sets of guidelines from both the IDSA and the AGA, the American Gastroenterological Association. And the way to classify C. diff is either by initial versus recurrent episode, which has the most differences. An initial episode, usually you get away with, you can do a pulse of fidaxomicin or vancomycin. When you start getting into recurrent C. diff, you start choosing more fidaxomicin or reaching for those vancomycin pulse taper regimens, the ones where you have the 10 days followed by kind of a de-escalating amount of doses per week. The key here to recognize is fulminant C. diff, which is defined as hypotension, shock, ileus, or megacolon. In those patients, you're still always going to reach for vancomycin, higher dose QID. And if your patient has ileus, you're going to think of rectal vancomycin or metronidazole IV. Questions about that? Okay, so this is kind of a key slide, I think, for the MKSAP to review. For your clinical knowledge in the wards, how many folks have used fidaxomicin for their first C. diff episode? Have you guys used that a lot? No, you have. Okay, Sandra has. So great. So this is a question that's coming up more and more. And fidaxomicin was initially approved more than 10 years ago. Like vancomycin, it has minimal systemic absorption, so it all stays in the gut. But unlike vancomycin, it has more limited activity against other gut bacteria. So it doesn't just blast your gut flora away like vancomycin does. And that clinically translates to decreased recurrence in the most common C. diff strains. So it's a little bit better at preventing recurrence. It's costly if you look at it from per course only viewpoint, but if you start adding in the cost of decreasing recurrence, then it's either equivalent or actually more cost effective than fidaxomicin. We're still trying to key into the population that will benefit the most from it, but the current IDSA guidelines at least recommend use for initial episode if at risk for recurrent CDI. And these are the risk factors for that. This is a typo, they should say initial episode. Also, for your clinical knowledge, this is too new to be on the MKSAP this year or the next year. For patients with multiply recurrent CDI, there's 3 agents to help prevent recurrence. So if your patient is on their 3rd or 4th or 5th episode of CDI, start thinking about these and consulting GI or IV. These agents are a monoclonal antibody, beslotoxumab, and 2 commercially available fecal microbiota transplant agents, Raybiota, which is an enema, and Vals, which is an oral capsule. And this is just my approach. I'll skip it. You guys can review it. All right. Question 3, syphilis serologies. Here we go. What did you guys answer for this question? B, no further testing or treatment was the most selected answer. Fantastic. Yep. And that is the correct answer. Because the patient had a positive treponemal antibody, but a negative non-treponemal antibody, and they had a history of treatment. Fantastic. So syphilis is one of my favorite infections. And just a quick reminder of the different stages of syphilis. You have infection, which leads to primary syphilis, which is your painless chancre at the area of exposure. After a few weeks, you get secondary syphilis. So that's the disseminated rash, which is classically maculopapular, involving the palms and soles. It doesn't always happen that way, but that's the classic presentation. Then you have these mucus patches with a grayish membrane, usually on your mucosa. And then you have these patches, usually in the genital area, also with a grayish membrane. After that, most patients go into latent syphilis, which is asymptomatic with positive serologies. And if you let things go on for too long without treatment, you can get tertiary syphilis. The main presentations are aortitis and gumma, which are little syphilitic nodules in your body. Quick reminder that CNS involvement can occur at any stage of syphilis. And kind of the crux of the question here is how to diagnose it. There's essentially 3 ways: direct microscopy, which a lot of folks don't use anymore, and 2 types of serologies. There is non-treponemal serologies, your RPR, your VDRL. These are antibodies against cardiolipin released by the host cells that are damaged by syphilis. They decrease after treatment, so they're active with disease activity. And you have treponemal serologies, which are your ELISAs, your TPPA, your FTA. These are antibodies against the treponemes themselves, and because of that, they remain positive for life. Yeah, that's about it. Any questions about syphilis serologies? I know this comes up a lot. All right, no questions. All right.
I had a question.
Yeah.
Sorry, so if it was reversed, where the RPR was positive and the treponemal antibody was negative, would it still be just a past infection?
So that would be a very unusual situation. If your RPR is positive, your treponemal antibody should always be positive if you have a patient with actual syphilis. But if you ever have that situation, then you start thinking about biologic false positives, which is this little row here. So you start looking at other causes for that positive RPR. So do they have another infection? Do they have lupus that is active? Do they have HIV? Things of that sort. Does that make sense?
Thank you. Yeah. Yes, it does.
Of course.
Sorry, can I ask a question?
Yeah, please.
So there were 3 tests that were listed for this patient. One of them was listed as the syphilis enzyme immunoassay. Is that the same as the treponemal, or is that a different?
Yeah. So great. So treponemal antibodies come in different flavors, right? So the classic med school thing we learned is a TPPA, but there's also an enzyme immunoassay, an ELISA or EIA. So that's also a treponemal antibody.
Sorry, one more question regarding
Please.
So with the RPR in the question statement said it was negative, that just means that the titer was like so high, like 1 to 512 or something. I don't know what a high number would be, but is that what that meant? So it never goes away, right?
The RPR titer. No, so the RPR is non-treponemal. So that should go away after treatment. So that probably means that the patient was treated. Does that make sense? Here, let's,
Okay.
yeah.
Uh,
Yeah, let me see if I have the stem right in front of me. Let me pull it up.
Maybe I think I'm wondering in real life, would the RPR ever like?
Oh, will your RPR ever be negative when you actually have syphilis?
Yeah.
Is that the question? Oh yeah,
Yeah.
that's a great question. Yeah. So that's a fantastic. I love that question. So yes. So the answer is yes. So if you get infected and it's very early on, your RPR can be negative in about a third of patients. If you have very early infection and your body just has not had time to react, right? Also, if you had syphilis for a very long time, your RPR can be negative because you have, quote unquote, burned out your inflammatory response. And that happens also in about a third of patients. In all those cases, though, your treponemal antibody, your TPPA, your EIA, that one will always be positive if you actually have syphilis. Does that answer that question? And then you were asking about the RPR being so high that it could be negative, right? And that's also a possibility. It's something called the prozone phenomenon. It usually happens in patients with secondary syphilis. And I didn't include a slide on this, but the way RPRs are positive when there's a balance between the antigen and the antibody. And the prozone phenomenon is when you have just way too much antigen that's overwhelming the test, so you get a false negative. But labs know about that and correct for that nowadays. Does that make sense?
Yeah, that makes sense. I think I wasn't
Yeah.
smart enough to ask the right question, but that was really helpful to hear.
Good. Yeah, no, syphilis serologies are like one of the more confusing serologies out there. It involves a lot of clinical history, their past RPRs, kind of getting a sense of where they're at in their course. But good. Any other questions? Yeah.
Can you see the questions that have been typed in the chat?
No, I cannot.
Okay, Lena said, and maybe you already covered this answer. Lena said, if the patient had not been treated for their prior infection, what would you do in that situation?
Yeah, that's a great question. So the reason we can say that this patient has treated syphilis and there's no further treatment is because of that history that they've been treated for their prior infection. If they did not remember that, or if we did not have documentation of that, we would have to treat them either for syphilis, for early syphilis or latent syphilis, depending on their last RPR.
And then Sophie said, and to confirm, higher RPR bottom number equals more disease activity, like 1 to 64 worse than 1 to 1.
Yep. So yeah, so more inflammation, essentially more damaged cells being destroyed. Yeah. Fantastic. I love this. Like I said, it's my favorite. It's one of my favorites. All right. I will leave this other slide for your review. This is the sequence in which we do these tests. UW, VA use the reverse sequence algorithm. And you may get asked questions about treatment on your MKSAP. Here is that slide that will help you remember that. It's essentially penicillin. IM without CNS involvement. If you have CNS involvement, IV. All right. What did people choose for question 4, treating ESBL UTI? Oh, I didn't see the answer there. I think it just went away. Oh, there it is. All right. 92% D. All right, great. Great. Yeah, no, it pains me to say, because I'm not a fan of carbapenems, but that's the right answer. Fantastic. So everyone did great. This is just a fun slide with the 8 different types of resistance. ESBL enzymes is one of them. It's kind of the notable thing there. And when we talk about resistant gram-negative rods, there's 3 phenotypes we think about. There's your AMP-Cs, which are usually susceptible to 3rd generation cephalosporins, ceftriaxone, but become resistant once you expose them to those agents. And we treat them with cefepime or 4th generation cephalosporins. You have ESBL, as in this case. Those are usually resistant to ceftriaxone and also resistant to other beta-lactams except for carbapenems. And you have CRE, the scariest one of them all, because they are resistant to everything that we're used to, including carbapenems. There is fantastic guidelines from the IDSA that tell you how to treat ESBL isolates. And it all depends on the type of infection you have, cystitis, pyelonephritis, or non-urinary infections. That's essentially kind of your branching point there. So this is going to be a useful slide to review for you as well. Questions always come up clinically about whether or not we can use cefepime or Zosyn if you have an ESBL isolate, so ceftriaxone resistant, that is sensitive to those agents in vitro. And the answer is yes, if you have cystitis, just cystitis, and your patient is on it and already getting better. Everything else requires you to switch to a carbapenem or something that's active, whether it could be a non-carbapenem as well. This is just if your ID attending ever shows up and you want to sound cool, mention these 2 trials stating that. This trial looked at whether we could use cefepime or pip/tazo instead of ertapenem for ESBL E. coli pyelonephritis. They had to stop recruitment into the cefepime arm early because of mortality and poor clinical response. Then there's the Merino trial that people talk about, and this one essentially found it did not find that using pip/tazo was not inferior to using meropenem in patients with ESBL bloodstream infections. So don't use those guys if you have ESBL. I will not go into AMP-C production, but you guys can review the slide. It's very cool. And it has a little chart here telling you what to use. Same with treatment of CRE isolates. But those you guys can review on your own time. Any questions about ESBL, AMP-C, or CRE in general? All right. Let me know if there's anything in the chat. But it doesn't seem like it. PIC-associated coag-negative staph bacteremia. How do you manage that? B, remove the PIC line and repeat the blood cultures. All right. And let me move here. And yeah, so the key point here is that coag-negative staph is less virulent than Staph aureus and less likely to cause metastatic infection or endocarditis in patients without prosthetic devices or endovascular hardware in place. and it may be treated with simple removal of intravenous catheter. So I think the answer is actually C. Correct me if I'm wrong, Sandra, but you can just remove it and be done with it, right?
I think that was what D said, though, right? Wasn't it just remove
so
the PICC line?
No, I think C was remove the PICC line, and D was remove the PICC line and get follow-up cultures.
Oh, yes. You probably are correct. I can find the answer, though, but
okay,
yes.
great.
Yeah, that's correct. D was get follow-up blood cultures.
Yeah, so great. So this is great chance for learning. So this one asks two different things. One, how do you manage central line associated bloodstream infections? And I always like to define the infection I'm dealing with. For CVC infections, you have a lot of superficial infections depending on the type of catheter you have: exit site, pocket, tunnel infection. These are superficial infections. You have separative thrombophlebitis, which is essentially positive blood cultures with a clot around your catheter. That usually requires longer treatment, removal of the catheter, as you'll see. Then you have colonization, which is when you have just a positive culture from the catheter, nothing else, no clinical symptoms, no positive peripheral cultures. That's it. And then you have bloodstream infections. Ideally, we want to see a peripheral blood culture or a catheter tip culture to make the diagnosis. But you can make a presumptive diagnosis with less data than that. And that's usually where we find ourselves when we're consulted. This slide walks you through the management of central line infections. The first question you have to ask is, am I dealing with a complicated infection? Meaning, is it recurrent? Is it persisting? Is there a superficial infection, one of the ones I mentioned, phlebitis, some other endovascular or metastatic infection, or is a patient pretty sick? If the answer is yes to any of them, you remove the catheter, no questions asked. Well, you can always ask questions, but remove the catheter is what we'll probably say if you ask us. If it's not complicated, then you look at the organism you're dealing with and how virulent and sticky it is. If you're dealing with a candida, a Staph aureus, or a Staph lugdunensis, a Pseudomonas resistant gram-negative rod, you typically remove it. If you're dealing with more sensitive Enterobacterialis, like an E. coli, a Proteus, pan-sensitive, coag-negative Staph, like our patient. If it's a short-term catheter, a lot of folks will say remove it. If the catheter is short-term, you don't need it. If it's a long-term catheter, dialysis lines, tunnel lines, things like that, we can treat through it. Same goes for Enterococcus species.
All right, sorry, Louise. I stand corrected really quick. I'm going to put it in the chat here. The official answer from MKSAP actually is to repeat the blood cultures, but what they say, a coag-negative Staph often resolved with removal of the catheter. Blood cultures should be repeated. Alternatively, patients with coag-negative Staph can be treated with antibiotics for 5 to 7 days if the catheter is removed. And for 10 to 14 days in combination with antibiotic lock therapy if the catheter is not removed.
Yeah. Okay. Sounds good. I stand correct. I mean, that practice is fine. I was just not sure of what. So you guys are all right. Sorry about that. Great. The other question is, when do you worry about endocarditis or metastatic infections when you have a positive culture? And essentially, the answer there is it depends a lot on the organism and other clinical factors. This is just a summary of different studies through the ages, looking at what percentage of people with a positive blood culture had endocarditis. So when you look at Staph aureus, before we had antibiotics or modern healthcare, most patients, 70% of them that had a Staph bacteremia had endocarditis. Now that patients are coming into the hospital a lot more quickly, the number has decreased by a lot. But if you see here, it's still a 10 to 14% number of patients. So these folks, Staph aureus, and also Staph lugdunensis, these patients always get a TTE, and the threshold for getting a TEE is pretty low. Coagulated Staph bacteremia, other than Staph lugdunensis, patients with that almost never have endocarditis. You only see it in patients with prosthetic cardiac devices, prosthetic devices elsewhere as well. So for these patients, the need for a TTE or a TEE is much, much lower. These are just some other factors to consider for increasing your pretest probability of endocarditis: multiple prolonged blood cultures, prosthetic material, previous endocarditis, not knowing how long the bacteremia has been going on for, and different metastatic infections. Unrelated, TTEs, not very good for identifying endocarditis in terms of sensitivity, if you're really suspecting it. All right. Any questions about that? Again, apologies for not remembering the correct answer here.
Yeah, could I ask a question? So how would you recommend trying to differentiate between Staph lugdunensis and like Staph epi if we get coag negative before species ID?
That's fantastic. So your lab will, before species ID, to be honest, your lab will always different. Like, it used to be an issue many, many years ago, but most of the labs now have MultiTOF, which gives you an answer to the species ID within an hour to 2 hours. So this has become less of a problem now. So you should always know that you're dealing with Staph lugdunensis up front. And even then, you'll know before you make any decisions about TTE, TEE, and that sort of thing. So if you have a Staph, you'll usually see Staph. It'll say MEK-A positive, MEK-A negative, which is MRSA, not MRSA, and that will be your first decision in terms of whether I use Vanco or Cefazolin. Does that answer your question?
Yeah, thank God for MultiTOF.
Yeah, thank God for them. Yeah, and our micro folks. So yeah, they're great.
And then actually, Luis, before you go on, there was a question kind of from the prior case. That was, how common is cefepime-induced altered mental status actually? And if otherwise indicated, should we consider avoiding in someone already altered?
Yeah, no, that's a good question. So it's common, but if it's what's indicated for that patient, I would not avoid it, and I would just monitor. And there's things that make it more common or more likely to happen, and that's essentially CKD and a really high dose. So if you have a patient that has pretty normal kidneys, it's unlikely to happen if you're using the standard dose. But if you have a patient that's in the ICU, has really bad AKI, and you're like using a super high dose, then you're really worrying about it. But upfront, I think if your patient needs cefepime, you use it and you monitor.
Okay, and then thank you. And then and then somebody says even if it's renally dosed.
That's less likely. If you renally dose it, it's less likely to happen. The odds are lower. Yeah.
Okay, and then for this last question, the question is, in this case, since you only got peripheral cultures, would you also want to get a line culture to confirm, or can you just assume it's infected?
Yeah. So again, I'm not sure what the STEM said. Did they not include peripheral cultures? Okay. I can pull it up.
Oh no, you were right there. Yep. Oh yeah, 2 sets of peripheral blood cultures are obtained.
Oh yeah.
That's what it says.
Yeah. So again, so in this case, it's one of these, you don't need to confirm with the peripheral cultures because it's not going to alter your management. It goes back to what's the source of this coag-negative staph bacteremia. And in the absence of any other prosthetic devices, it's the line. So, you know, I like to get them because I'm a completionist, but you don't need to get them in that sense. The answer is going to be the same in terms of management. All right. Great. So patient with diverticulitis and positive blood culture for yeast. Great. What did people pick for this one? Fantastic. You start empiric therapy with an echinocandin. Great, that is the answer. Yep, manage candidemia with empiric antifungal therapy. Should always be treated as, should not be treated as a contaminant, and empiric therapy with an echinocandin should be instituted immediately. That's a key teaching point. So this slide, I think it's helpful. The main point again is as soon as you have a patient with a positive blood culture with candida or yeast, you start that echinocandin, caspofungin, or mycofungin. Once you know the organism, at least, you can start de-escalating a little bit. Things like C. albicans, C. tropicalis, C. parapsilosis, Lusitaniae are usually sensitive to fluconazole. The ones that you have to watch out for in terms of resistance to fluconazole are C. glabrata, C. auris, and C. geyermondii. Most of these are susceptible to echinocandins, but you'll see a sporadic resistance here and there for parapsilosis, auris, and geyermondii. Other things to do when you have a patient with candidemia, you always get susceptibility to fluconazole and echinocandins. The labs should be doing this. You always get repeat cultures to ensure that you cleared that candidemia. You control the source, you remove that CVC, you get that CT abdomen pelvis, see if there's any abscesses there, that kind of thing. There's data that shows that an infectious disease consult is beneficial, and at the VA, this is an auto consult. The IDSA guidelines suggest dilated eye inspection within 5 to 7 days for non-neutropenic patients and after granulocyte recovery for neutropenic patients. This has become controversial in the past 2 to 3 years because of different guidelines from the American Ophthalmology Association. I don't know if you guys have had this issue or encountered this in your clinical practice. No? All right. Well, great. But just so you know, there is competing guidelines. In 2019, there was this big meta-analysis essentially saying that there's no evidence that screening for ocular candidiasis in patients with candidemia that are asymptomatic improves outcomes, and that it may lead to unnecessary interventions and harm. But like I said, there is a debate, and proponents of screening say that ocular candidiasis occurs in about 10% of patients. It's a sign of disseminated infection. It can be asymptomatic in many patients. It changes the duration of therapy, and both screening and treatment is safe for the most part. You might come across that. And then echocardiography is persistent candidemia, and there's increasing practice of doing it if you have a patient with cardiac prosthetic material as well. Again, this is other tidbits, more clinical. I think the more controversial aspects probably won't be on your tests. All right, question 7. What did this patient with MRSA bacteremia and that slightly high MIC get for treatment? And I should ask if there's any questions about candidiasis, let me know. Or candidemia, I should say. Oh man, keeping me in suspense here. All right.
Sorry, I shared it.
Oh no, that's good. Okay. It was great. That's great. That's a great spread. Fantastic. We have most people picked D, well, which is the correct answer, and then we have an even spread on the other answers. Great. So good. When treating MRSA bacteremia, vancomycin should be used only if the MIC is 2 or less. So there's different types of Staph aureus in relation to their sensitivity to vancomycin. Most of what we deal with are vancomycin susceptible Staph aureus, defined as an MIC less than 2. You treat it with vancomycin, as in this patient. When you start seeing higher MICs, 4 to 8, over 16, over 32, you start thinking of specific resistance mechanisms and reaching for dapto or linezolid. Depending on the situation, you'll be consulting ID here, so that's okay. I'll skip this. You can review the mechanism of vancomycin resistance. I think the spirit of this question, it used to be that we would worry more about these elevated but still susceptible vancomycin MICs between 1 to 2, based on a couple of clinical trials from around 2012, 2013 that found increased 30-day mortality among those patients. But those studies included polymicrobial infections, didn't adjust for confounders, used e-tests, which usually give you higher MICs, that broth microdilution, which is what the gold standard is and most places use. And newer studies have found that there's no, that actually corrected for these, found that there's no significant difference in terms of mortality for those isolates. As long as your MIC is less than 2 or 2 or less, then you're fine. And in general, you select treatment for these patients based on their clinical response rather than the MIC range. That's it. Any questions about MRSA and slightly elevated MICs? Great. Non-purulent cellulitis, cool. What did people answer for this one? Let's see. Sorry, let me just look at the stem on this one. Okay. B or C? Yeah, that's fine. Was there no Keflex for as an option for this answer? That is surprising. Okay. Interesting. All right. Well,
yeah, I did not love this question.
Yeah.
I can go and find the original one and like cut and paste whatever kind of things they say, but
that's fine. The real answer is cephalexin or dicloxacillin. But for this question, the best answer is anything that's oral. So the clindamycin would be, I guess, what you reach for, because in vitro there is more the activity against strep is more reliable for clindamycin than it is for Bactrim or doxy. So that's what you would reach for in this case with that. I guess there's a Keflex shortage, and that's the only things we have. So all right, bacterial, skin, and soft tissue infections. Again, I'm a fan of categorizing what I'm dealing with. SSTIs or superficial infections, impetigo, ecthyma. And the IDSA guidelines from a long time ago now have this nice kind of an algorithm. The first branching point, are you dealing with pus or something without pus? And then you think about, and that basically tells you, if you have pus, you're dealing with Staph aureus. If you're not dealing with pus, you're dealing with strep. And then the severity of infection tells you what you can treat with. This patient had pretty mild symptoms, no systemic symptoms. So you're reaching for those cephalexin, diclox, or clindamycin. Moderate infection, so that's patients with at least one systemic sign or symptom. They get IV therapy. Super sick patients, the ones that are in shock or you're worried about an STI, you kind of open the floodgates and treat them with everything. Just some cool pictures of what impetigo and ecthyma look like. Again, and same with cellulitis and erysipelas. And just a different way of telling you what I just said in the previous slide. People ask, should I add Bactrim to my Keflex for these uncomplicated non-purulent SSTIs? And the answer is no, you don't have to, because of a study from 2017 that looked at that very question, and it found that the combination was not superior in terms of cure. But you can consider it in patients that were excluded from that study, penetrating trauma, IUD, immunosuppression, MRSA colonization. And that's all I have in terms of the pre-prepared slides, but I think there's more questions. Question 9.
Yeah, so if you go, it's just after those 2 extra slides that you had in there. So just scroll through. So these you had in there, and then I went to question 9. And then I just for you, Louise, I put in for the chat like what MKSAP said, and I think their explanation was like kind of trying to trick you, because it did talk about I'm not trick you, but it wants you to know like beyond Keflex and beyond penicillin, beyond dicloxacillin, that Clinda also covers strep. I think that was the point of the question. Right. Yeah.
Sweet, I got it right.
Yeah.
Okay.
Can I ask also, I feel like this comes up a lot in these patients who have an extensive history of, say, MRSA infections, and then they have a non-purulent cellulitis.
Yeah.
They get admitted, and then they turn around quickly, and we go to discharge them, and the conversation about double coverage comes up a lot. And it's like, do we send them out with Bactrim and cephalexin? It feels like a lot. Like, I know you mentioned MRSA colonization. I'm just curious what your approach is there.
Yeah, I think it depends on what they got better with as an inpatient, right? So if you started cefacillin and they improve with just that, then that's easy. You send them out on Keflex to continue that, right? Because you're not covering MRSA. If you did Vanco instead, for whatever reason, it becomes a little bit tougher. And then, depending on how severe the infection was, if it was pretty mild and there's no pus, I de-escalate to Keflex. But if it was more severe, more involved, they were on IV antibiotics for longer, I hedge my bets and I add the Bactrim, especially if they're colonized with MRSA. Yeah.
I just feel like a lot of times practically what happens is they get a dose of Vanc and ceftriaxone and ED, and then the next day they look better. And I'm like, I don't know what made them better.
Yeah.
I send them out with.
Yeah. That's a good point. In that case, you kind of rely on this, right? So if there's pus, then MRSA for sure. But if it's non-purulent, and they don't have any of these things that I'm listing here, then super reasonable to use to Keflex at that point. Yeah. Does that help? I don't know.
Yeah, thank you.
Okay, yeah.
And Louise, Lily had a comment about the Harborview population. And so I guess specifically in your like IVDU population, even if you don't see purulence, do you then cover for MRSA empirically?
Yeah, so that's one of the populations that was that where you could add MRSA coverage. And the pathophysiological reasoning there is that if they have MRSA, they're at higher risk for an endovascular infection, and you don't. And it's it's not great to, and you want to prevent that as much as possible. So that's why those patients were excluded from this study. So patients where they might have abnormalities or behaviors that increase their chances of having endocarditis down the road. That's why they excluded those patients from that study. So those patients I usually give additional Bactrim unless, if there's questions there. So, yeah. Great. The answer for this one was A, fantastic. Cystoscopy and biopsy. Yep. So patients with asymptomatic bacteriuria, you only treat them if they're pregnant or if they're about to undergo a urologic procedure with mucosal breakage. A lot of people pick kidney transplant, total hip arthroplasty. For kidney transplant, the transplant guidelines will tell you that you could treat them if they're within their first month of transplant and have asymptomatic bacteriuria. But the IDSA guidelines don't really talk about it. So that's something that you could do. It's reasonable. I don't do it, but other people can. So yeah. Next question. Manage uncomplicated pyelonephritis with bacteremia secondary to E. coli sensitive to Cipro. Yes. And we have 5 minutes left, so maybe we'll see how we do after this one.
Yeah, and we can actually go till 10:35 because our next talk is until 10:45 if you're able to stay on.
Oh, yeah, happy to do that. All right. Ooh, I like it. Completion of oral Cipro course, got 48%. Then extend the Cipro for 2 weeks, got 36%. And a couple of other answers. Great. So the actual answer is just completion of a 7 days oral ciprofloxacin course. And that's actually a fairly new development. It used to be that we would extend, or we didn't know what to do. So a lot of folks would extend therapy for 10 to 14 days if they had bacteremia. But there's been a few pretty good studies, I want to say 2 to 3 years ago, where patients without structural abnormalities, with good source control, i.e. exchange of the Foley, do just fine with 7 days of Cipro if they have pyelonephritis associated bacteremia. That's a teaching point there. Similarly, there's also a few studies looking at whether or not you need follow-up blood cultures in patients that have gram-negative bacteremia, and again, very unlikely to have persistently positive blood cultures in the absence of like an abscess or something like that. So you don't need to do that either. No questions about that. I will move to the next one. Urinary tract infection in a male patient. What did people choose? Oh, great. A spread. IV cefepime and kidney ultrasound had most votes, and that's the correct answer. Yeah, so the teaching point here is that patients who have, I guess, men that have UTIs and are very sick should get a renal ultrasound to exclude any structural abnormalities, kidney stones, abscesses, things that you need to source control. And that's a teaching point here. I don't see this happen a lot in practice, but that is the textbook answer, and MKSAP knows that. Questions about that?
Should you evaluate for like prostatitis here?
I think, again, this is one of those things that in practice, it doesn't happen. But I would have a low threshold to do it. So if the patient was having recurring UTI symptoms, if they said, hey, it hurts when I sit down, if they have like symptoms that make me think of prostatitis, then I would do a prostate exam. If they have chandelier sign, then yes, I will probably treat for prostatitis at that point.
Yeah, the MKSAP answer, they talked about how the digital massage could increase your risk of bacteremia, and that's why that one was like not the right answer. And for the folks that chose the IV or the CT, it's only because he has a creatinine of 2 that was wrong. Like otherwise, D could have been just as right as the one with the ultrasound and cefepime.
Great. So next question, people picked ganciclovir or no additional therapy. I like that. Okay. So the answer is B, I believe. And the reason for that is because this patient, so when you look at patients with a solid organ transplant, you have to think about how far their transplant was and what type of immunosuppression they got. So this patient had their transplant, I think 7 months ago or something like that. So normally, they would be outside of that 3 to 6 month window where, CMV infection is the highest. But they just recently got graft versus host disease, which is usually another round of T cell depleting therapy, and that's why they're also at high risk of CMP. And also their clinical picture is most consistent with that, with the multiple bilateral opacities, diffuse bilateral opacity. So yes, so you start ganciclovir in that patient would be the answer. I don't know if there's any other teaching points that they wanted to make. Oh yes, once you have CMV in one place that's disseminated in these types of hosts, you want to ask at least questions for symptoms eliciting involvement of other places as well.
Yeah, and they just highlighted that although she's on acyclovir, that's not going to cover your CMV.
Yes, I didn't see that. Yeah, but that won't cover the CMV, yeah. Great. Is that it? That's it. Wow, we got through all of them. Great. Questions in general about ID or life? All right. It's not.
Okay, awesome. Thank you to both of you, Dr. DeMars and Dr. Tulloch. If it's okay with both of you, I will circulate the answer slides so people can review them on their own time as well.
Yeah, that's good. All right. Good luck.
Thanks
good
so
luck on your
much.
test.
Okay,
Bye.
thank you.
Thanks for being here, everybody.
All right, so we will have a break now until 10:45.